All right, hello and welcome to this overview of hypothyroidism and hyperthyroidism. Of the affected systems, the primary one that gets the most attention is the hypothalamic pituitary thyroid or HPT axis, wherein the hypothalamus releases thyroid-releasing hormone that in turn stimulates the release of thyrotropin from the anterior pituitary. This hormone is otherwise known as thyroid stimulating hormone, abbreviated as TSH, and even in literature that only refers to this hormone as thyrotropin, TSH tends to be the abbreviation that's used. And the thyroid hormones from the thyroid itself include T4 and T3, as well as RT3 and T2, with T4 and T3 being the main ones that we pay attention to, especially with T4 being the most prevalent and being the biggest source of T3 as T4 converts to become T3, hence the yellow highlight, T3 being as important as it is. So now, when the HPT axis succumbs to hypo or hyperthyroidism, here is some general uh, observations that you can expect. First, for euthyroidism, or for a healthy thyroid, normal ranges are less than or equal to 4.5 milli-international units per liter. Um, Whereas with T4 and T3, you'll see your normal ranges as 0.7 to 1.8 nanograms per deciliter, or 2.0 to 5.0 picograms per milliliter, respectively. And these are pretty good thresholds to keep in mind. And originally I had numbers in the rest of these boxes and just felt a little confusing when generally compared to these typical ranges, um, you go based off of elevation or reduction from that. So in subclinical hypothyroidism, you can expect elevated thyrotropin with no changes to thyroid hormones themselves. So yes, there is um, altered uh, endocrine production, but not to the point where it is affecting the end organ, the thyroid. But then when you move on to the clinical presentation of primary hypothyroidism, you will see elevated thyrotropin just as in subclinical, but now reductions in circulating levels of T4 and T3. Now, moving down the road to the other end of the spectrum, it's subclinical hyperthyroidism. Thyrotropin is so low it's undetectable. But even with that change, just as in subclinical hypothyroidism, thyroid hormones do not see a change in circulating levels. However, in primary hypothyroidism, the clinical presentation, not only is thyrotropin reduced, but you'll see an elevation in thyroid hormones. So basically, the hypo and hyper of the prefixes for these conditions refer to that end target, to the thyroid hormones themselves. So in hypothyroidism, you can expect reduced thyroid hormones. In hyperthyroidism, you can expect elevated um, levels of these thyroid hormones. There's also central hypo and hyperthyroidism, which um, have more to do with the hypothalamus and the pituitary gland having dysfunction rather than uh, primary form where we see that dysfunction in the thyroid itself. Overall, those the rules of what you'll see observed are about the same, except in central hypothyroidism, you actually see reduced thyrotropin, which is interesting because you'd expect that to be hyperthyroidism, but that's not what happens. There are additional affected systems um, in hypo and hyperthyroidism. In the adrenal glands, at the end of the HPA axis, there is a noted effect on cortisol. In hypothyroidism in particular, cortisol is elevated, and it correlates with what you expect to see in hypothyroidism. So there's a positive correlation. The rise in cortisol is relative to the rise in thyrotropin, whereas the rise in cortisol is negatively correlated with thyroid hormones. So cortisol goes up, but thyroid hormones go down, just as thyrotropin goes up. So there is a direct relationship observed between cortisol from the adrenal glands and thyrotropin from uh, the anterior pituitary of all things. So it just demonstrates a continued interrelationship between the various axes and pathways of the endocrine system. Then also in the gonads, estrogen and testosterone have demonstrated um, changes in the presence of altered thyroid function. So in hypothyroidism, you tend to see reduced sex hormones. So estrogen and testosterone, male or female, these sex hormones do see a reduction. And also, it has been observed that for every one standard deviation change in testosterone, I'm sorry, and that is that is a typo. Pardon me. That should actually say in thyrotropin. For every one SD change in thyrotropin, you will see a change in testosterone of approximately 0.103 nanomoles per liter. And as you can see, it's a fairly significant difference from euthyroidism. With a p-value deep down at 0.0009. Also, sex hormone binding globulin (SHBG) um, is is a marker worth paying attention to for risk of of thyroid dysfunction and dysregulation. So, low SHBG predisposes men and women to hypothyroidism, whereas high levels of this substance predispose men and women to hyperthyroidism. Uh, and of course, nothing is in a vacuum. Simply having low or high levels of sex hormone binding globulin do not guarantee that a diagnosis will be present for altered thyroid conditions, but it is still a thing worth noting. And again, as we said with the adrenal glands, um, there is a lot of interconnectedness in the systems of the human body. As far as exercise interventions go, resistance training has been observed to increase the anti-inflammatory response of patients with Hashimoto's disease, which is generally considered autoimmune hypothyroidism. And then in patients with autoimmune hyperthyroidism, otherwise known as Graves' disease, T4 levels can be reduced by aerobic training, and thyrotropin levels can be increased. However, one thing worth noting is that p-value for TSH. The study had set its own significance at 0.05. It's still worth noting, like, yes, it's approaching perhaps significance. And as we've been taught at various points in our education, um, 0.1 can be a significant value worth discussing, which is why it was included here. But as far as true significance from the study here by Hudovik et al. From 2012, um, there was a change, but it's arguably a non-significant change. But still, there was an impact on thyroxine levels, and so it's good to know that there are exercise-based interventions that can help with managing hypothyroidism, and also there have been with patients experiencing hyperthyroidism a discontinuation of thyroid medications following um, uh, chronic physical activity. So there is hope. Future research can go in a bunch of different directions, but just from my dives here and the walls I ran into while trying to find things, it'd be good to look at athletic development for altered thyroid conditions, because the research tends to speak on patients, and of course, because you are at a deficit in baseline compared to healthy subjects when you have hypo or hyperthyroidism. So, of course, dealing with finding ways to deal with the altered thyrotropin and thyroid hormone levels is of course a priority. But um, in a able positive world, we should also be finding ways that not just to manage conditions, but to allow individuals suffering from various endocrine disorders to be able to pursue athletic interests if they have them, or at the very least be able to work out and have the same goals as the other people that see in the gym. They want to build muscle, lose weight, be more agile, improve their balance, these kind of things. We could use more research where the subjects involved are those with hypo or hyperthyroidism looking to achieve improved athletic performance or other aesthetic goals. And exercise-based preventative measures. Like, is there a way that we can not only recognize increased risk for altered thyroid function, but also to follow an exercise program that would help reduce that risk? And on with that, research into lifestyle choices such as exercise or diet that pose risk factors for hypo or hyperthyroidism. Anecdotally, I know of cases where extreme dieting, people who were doing extreme dieting, ended up having hypothyroidism. But again, that's anecdotal. Like, I know that they ate this certain way, and at some point they were diagnosed with hypothyroidism. But whether or not there's actually a link there, I found a little bit in literature, but not enough for me to say that there is a good body of evidence there. But there could very well be. We have a lot of things that we look for while we're in this program, and it's easy for things to be missed. So, yeah, as always, standing on the shoulders of giants, here are the studies I looked at while creating this presentation. Yeah, so in review, hypo and hyperthyroidism greatly impact the HPT axis, but they also can affect the HPA and HPG axis, as well as other organ systems involved in metabolism and stress responses. So, yeah, there it is. Chip, chip, cheerio. Have an excellent evening or afternoon or whatever it is, wherever you are, while watching this. Toodaloo.